Good afternoon, everyone. Sorry for the delay, but we want to welcome you and thank you for joining us today for our Hope Has a Home webinar. My name is Nicole Granger. I'm the Executive Director of Fundraising and Development at Volunteers of America Chesapeake and Carolinas. Before I turn it over to our moderator, Stephen Samuels from Volunteers of America, let me briefly walk you through a few logistical items. Next slide. Perfect. So you should see a control panel on the right-hand side of the screen. You can click the orange arrow to hide the control panel. And just so you're aware, all of our attendees are on mute except for our speakers by default. And if you have any questions about the webinar technology or questions for our panelists, please type them in the question box in the control panel. You can start typing while our panelists are speaking, and then we will be going through those questions at the end. The webinar is being recorded, and we will make sure we share a link to the recorded webinar in a follow-up email later this week. We will have a couple of poll questions during the webinar, and so just to sort of kick us off, we're going to go ahead and throw one up for you now so we can get to better know our audience. So we'll give you a minute or so to fill that out. All right, we'll give you just a little bit longer. See, there's a few people still making their entries. Okay, perfect. Thank you for doing that. So just so you're aware, again, you can type questions in for our panelists today, and we have reserved the final 15 to 20 minutes of the webinar for Q&A. And I will rejoin you to help facilitate the Q&A portion of the webinar. We've finished the poll questions, and now let me turn it over to our colleague, Stephen Samuels, the Vice President for Innovation and Impact Investing at Volunteers of America National. Stephen?
Thank you, Nicole. Welcome, everyone. It's an honor, truly, to promote and facilitate this dialogue for something so profound, particularly during the pandemic. Much of my role at VOA involves engaging and diversifying our impact investor partners to scale up our housing and resident health services. And value-based contracting is a core driver of that strategy. And it's one of the reasons that I'm particularly excited about moderating the panel today. I'm thrilled to be amongst experts in this program. And they include Rosalind Carr-Stevens from AmeriHealth Caritas here in DC, Allison Ryan from Quantified Ventures, Dr. Catherine Crossland from Unity Healthcare, and Jana Burhow from our affiliate VOA in the Chesapeake and Carolinas. What the four of us or five of us all share is the belief that to effectively address the complex needs of individuals experiencing homelessness, a partnership-driven, value-based approach is required. And we believe that it's a model that can be scaled, not only here in DC, but replicated elsewhere across the country. So let me briefly set the stage for Hope Has a Home, and then I'm gonna turn it over to our panelists to share their insights. So there's a great need today for holistic approaches to mitigate homelessness. Now, we know that these vulnerable individuals are at increased risk for serious chronic and behavioral illnesses that are most often caused and exacerbated by their living conditions. And so that's why programs that are holistic and integrated that can meet the needs of the entire person are so important. So to kind of touch in again with you all and to highlight the scale of this problem, not only here locally, but nationally, we have another poll. I think this is number 2 of 3 polls today. And so again, using the instructions given to you on your screen, the question is, how many individuals are homeless, do you believe, on any given night in the United States? And I'll let my colleagues decide when they're going to share the results here, because I can't tell how many of you have filled it out. Give you a few more seconds. All right, let's see what you came up with. Can you show the results? Okay, the majority, half believe 609,000. So clearly as a group, I'm sure you know this subject matter, so you understand the scale of it. In fact, according to HUD 2019, 567,000 individuals are homeless on any given night in the United States, 500,000. And it's estimated that because of COVID, that number can increase by up to 40%, so potentially doubling. It's also estimated that of those 500,000 individuals, almost half, 220,000, are unsheltered, thereby living on the streets or in abandoned buildings, not getting taken care of. And of those 50% that are unsheltered, half of those individuals struggle with physical, mental, and substance use related issues. So clearly, we need to innovate in this space and bring solutions to bear that can address this crisis, both locally and nationally. And we think and believe deeply that Hope Has a Home is one of those solutions. It is a 16-bed medical respite program that provides clients with housing, behavioral health services, and wraparound support for individuals that are experiencing homelessness in DC. It is about partnership, as you can see on this slide. By working together, these core organizations, we have a program that is designed to specifically disrupt the cycle of frequent hospitalizations and homelessness, and ultimately improve the health of clients because of connecting them to housing solutions. Right now, the program only supports men in DC, so we are actively engaged and engaging with other MCOs in the DC market and other potential investors to not only expand that program, but to add comparable sites for women. So our goal today in the next 45 minutes is to provide you each with more insight into the roles that these various partnerships play, what has brought us up to this moment today, and what's our future vision for the Hope Has a Home model. So I don't want to waste any more quality time here. And I'd like to first turn it over to Rosalind Carr-Stevens with AmeriHealth Caritas D.C., who can explain really how and why AmeriHealth laid the foundation for this program. So Rosalind?
Thank you, Stephen. And I actually think Stephen did an excellent job of sort of saying how we got into this space in the first place. And again, I'm Rosalind. I serve currently as the Market Clinical Director for Population Health. And what that really means is the case management teams and coordination teams fall under my purview. AmeriHealth Caritas D.C., one of the family of companies with AmeriHealth Caritas, serves Medicaid and safety net beneficiaries in Washington, D.C. And if you saw the numbers in the previous slide, it really speaks to what we see every day and work with every day with AmeriHealth in Washington, D.C. When we speak about the impact of homelessness on healthcare, when we speak about the comorbidities and this milieu of complexities that individuals and families deal with every day, we could not operate as a health care organization without addressing some of these concerns. AmeriHealth recognized a few years ago that one of the greatest impacts to moving individuals and families to stable health care was the fact that they often were unhoused or transiently housed, and therefore the best discharge plans from a hospital, the best care plans by a case manager were not able to be implemented because they didn't have a stable place for those things to happen. If you imagine that I'm a diabetic and I need a place to store my insulin, if I'm on the street or I'm in a shelter situation, pretty soon I don't have my insulin, or pretty soon I'm in a situation that sends me back to an ED, and sometimes, unfortunately, to an inpatient hospitalization. The ability to dialogue with my care provider, with my specialist or my primary care provider is impacted because, again, I don't have a stable place for someone to reach me. So AmeriHealth recognized that in order to make any type of an impact, we needed partners in the community. So with our focus primarily being on individuals and families, we set out to see who was most impacted. And as Stephen mentioned, for our market, it was largely, first and foremost, adult males. And so that's where we started. A larger problem, but initially focusing on that group. And we recognized that we had to do more than set up appointments. We had to do more than set up transportation. We needed to address all of those supports that individuals who are housed and individuals who have food security would have. So we took this holistic approach that you see on the diagram, this whole person approach that says, in order for me to get to some of your core healthcare needs, I need to make sure you can eat. I need to make sure you have a roof over your head. And a roof over your head, by the way, in which you don't share with others in a traditional shelter situation. We need to concurrently work on health literacy in a place where you're getting that messaging in the place where you live. We need to screen for social determinants because those impacts change over time. And then most importantly is leverage the existing partnerships. Some of the individuals you'll hear from where you're already doing good work either in the housing space or in the social service space, and bring those partners together so that as we identify individuals whose health just is not moving forward because of these determinants, we have a holistic plan that's a throughput from the time you become ill to the time where you establish wellness. And then to continually assess where you're going, continually assess the impact, continually obtain feedback from those individuals who are participating in the program so that you see those improvements. Through the work of the individuals that you're going to hear from, we've recognized that, first of all, partnering with hospitals and having hospitals understand that we now can help with that individual you'd like to discharge, but there's no real safe place to discharge them. To talk with federally qualified health centers and primary care providers to understand that we may have to amend a plan of care so that this individual can become stable in the first 30 days, look at stability in the next 60 days, and then move forward. And I'm so happy that as you hear from us today, you'll recognize that we've had great success in this area. We've had individuals who were cycling, we began to know their names, quite frankly, because they were cycling in and out of healthcare. And now we have individuals who are at a level of stability where they can now be proud that they're self-managing and they're partnered with the right folks in their healthcare continuum to establish some stable healthcare. Thank you, Stephen.
Thank you, Rosalind. I'd like to turn it over to Allison Ryan.
Great, thanks, Stephen, and thanks, Rosalind. And it's so nice to be with you all, even if it's just virtually. My name is Allison Ryan. I'm the Vice President of Health and Human Services at Quantified Ventures. And we are an outcomes-based capital firm that works to drive transformational health, social, and environmental impact by providing consulting services, developing projects and partnerships, and structuring innovative financial transactions that help to drive the sustainability of those initiatives. And here's a little bit what that looks like in the context of Hope Has a Home. And I'll go back a little to the origin story here and really talk through the different aspects of our role throughout this effort. So when we started our work on behalf of AmeriHealth Caritas D.C, our very first task was actually to assess both historic claims data and secondary data from peer-reviewed literature to consider not only medical respite, but other innovative program models with the greatest potential to improve member outcomes, to enhance AmeriHealth's performance on key quality improvement indicators, and also to reduce spending. So it was sort of a holistic review of the evidence to see where AmeriHealth could drive the greatest impact through selection of a prioritized intervention. And through this exercise, we really developed sort of a playbook of high impact potential programs and then rated the strength of the evidence on outcomes delivered. We looked at the market conditions in DC, and we also worked with AmeriHealth to ultimately select the medical respite model as the one to move forward with. So having identified the priority program model of medical respite, we then worked to conduct an assessment of the service gaps in the market. And that really helps to inform many of the critical design features that you'll hear more about from the other panelists, and really that are needed to sort of see the program that we envisioned really come to life and have the impact that we had observed in some of the literature. We also reviewed several other best-in-class medical respite models from across the country, really to learn from the great work that's been ongoing in several other cities like Portland, like Seattle, like Boston, so that we could see how they approach several key features, such as the populations that were served, the services offered, the length of stay, settings and staffing models, the financing approaches, and other key performance outcomes that they were trying to drive toward. So with a better sense of what was needed and who was doing what, we then proceeded to engage with potential service provider partners in the DC market, really looking to assess their interest generally in working in this type of environment, the level of mission alignment, their capacity to deliver key services, the organizational assets they would bring to bear, and also, as Stephen mentioned, the openness to value-based partnerships with a Medicaid MCO. And through this iterative process, we were able to convene and coordinate across all partners and leverage both plan data from AmeriHealth and also really robust partner expertise to develop the ultimate medical respite program parameters, eligibility criteria, referral pathways, licensing requirements, operating plans, like the list goes on, but really fully baking that program model with all of the partners acting as part of the process. And then we worked, having defined that program model with partners, to estimate both the one-time startup and also ongoing operating budgets, against which we worked to optimize service reimbursement and to minimize the financing gaps that they would have going into program launch. And then finally, we sought inputs from all partners really to develop an economic model to project the return potential of the program based on anticipated participant clinical and social need characteristics, their expected participant volumes and utilization patterns, ongoing costs, and both clinical and economic outcomes of participants. So I will just wrap up by saying it's been an immensely gratifying experience to be part of this team and to see what the program staff have been able to bring to life. And with that, I will turn it back to Stephen and Dr. Crossland.
Thank you, Allison. And let me use this opportunity to remind everyone, by the way, if you have questions, because already Rosalind and Allison have brought up a lot of interesting, compelling theories. So use your chat box and we will get to questions. And although I have some of my own, I certainly would rather entertain yours than mine when we get to that point. So next I'd like to turn over to Dr. Crossland with UHC.
Hi, thank you so much. My name is Catherine Crossland, and I have had the privilege of working for Unity Healthcare for the past 11 years. And for those of you who don't know, Unity Healthcare was originally founded in 1985 as one of the country's first healthcare for the homeless projects. And while we have grown to become DC's largest federally qualified health center in the city, we are still the largest provider of healthcare for people experiencing homelessness throughout the city. So we have still a very large healthcare for the homeless project. And I have been working as both medical director for homeless outreach, as well as now director for homeless outreach development, which essentially looks for gaps in care for people experiencing homelessness and to help partner, as in this wonderful partnership that we have here today. So I imagine that the majority of you know about medical respite. I know we've referred to medical respite, but just to define it sort of more basically, for those of us in the healthcare for the homeless world, medical respite is really an entity that's specific to homeless medicine. It is a place where people experiencing homelessness who are too sick to be on the street, but not sick enough to be in the hospital, can go to get the level of care that they need to usually treat an acute medical condition to get them back to a place where they can then return either, unfortunately, to the shelter or the street in some cases, but hopefully to a more stable housing. And as Rosalind mentioned, people experiencing homelessness have a number of social determinants of health that really work against their health and their health outcomes. Our population is increasingly older and incredibly medically vulnerable. And this has really only been highlighted by the COVID pandemic, where we are seeing quite old people really over the age of 55, 65, et cetera, the people who are the most at risk for complications from COVID with significant medical comorbidities, who are really just at in a really vulnerable place. So this, to me, really highlights the need for medical respite. Unity Healthcare has been doing medical respite since 1985 with Christ House, which is a freestanding medical respite program, again, only serving men. The only medical respite program serving women in the city currently is just a few years old, and it's for only 12 women. And so really, when we were approached by VOA and Quantified and AmeriHealth and Pathways for this partnership to expand medical respite to our patients, I say patients, other people say clients, but to those sort of medically vulnerable people experiencing homelessness in Washington, D.C., we were really thrilled at the opportunity to support this endeavor. So that's, from our perspective, it's truly a need that is being met and hopefully can be met further with expansion of the program.
Thank you, Dr. Crossland. A great description of the challenge and the problem. My colleague Jana, I'm going to turn it over to you to talk about how VOA is innovating in this space.
Sure, and thanks, Dr. Crossland. That was kind of a great segue into talking about our DC landscape and the structure of the program. I'm Jana Burhow. I'm the Vice President of DC Services for Volunteers of America, Chesapeake and Carolinas. And our Hope Has a Home offering in the district is actually in two phases. We have two 8-bed residential facilities in the city. In the first phase, it's the true medical respite that Dr. Crossland was just speaking about, where the clients that are identified to come to us are homeless men who have been inpatient in a hospital, perhaps in an emergency department, and sometimes in a SNF, in a skilled nursing facility, that need a safe discharge because they can't manage the medical condition for which they were admitted on the streets. So in phase one, based on that medical necessity, we bring the men into the first house where a nurse practitioner and an independently licensed clinical social worker work together in tandem with LPNs that staff the home 24 hours a day to provide that medical care and to start doing those initial psychosocial assessments around those social determinants of health, to see where people are at with, mental health, substance use, employment, education, other drivers of the homelessness that is really impacting their health and just their overall well-being. But that phase one house really is focused on restoring health and getting that person medically back to a place where they may not need that level of care. Then the men then have the option to move to the phase two house, which is a facility that looks just like the phase one house. These are beautiful 8-bed facilities with living spaces at the front and the back of the house, with big kitchens and eat-in areas. They really are homes. They're not shelters. But in that phase two, then that focus continues to be on those social determinants of health. It's staffed with what we call community support workers, for lack of a better term, because our background with VOA is largely mental health and substance use treatment. But it's staffed. It too is staffed 24 hours a day. And that focus is then again helping people move to permanent housing. And thus far, we've prevented 80% of participants from being readmitted to the hospital emergency room for at least 30 days after leaving the program. We've got about 75% of participants, actually I think that number's a little higher than that, that have obtained permanent housing within 6 months of interaction with the program. And we use a couple of different assessments as well. It's not just the kind of HEDIS measures that are important to our payer, AmeriHealth Caritas D.C., around low acuity, non-emergent admissions, all-cause readmissions within 30 days, and that ED/EMS use. But we also use the Adult Needs and Strengths Assessment, or the ANSA, to measure in a pre-test, post-test way whether or not we're helping the men reconnect to their social networks, helping them to reconnect to employment, to permanent housing, to those other indicators that show that life is getting better for them after coming into contact with our program. So we're pretty excited with those preliminary results. We had some challenges with implementation in the COVID year. Until we got really adequate testing for staff and for people served, we didn't ramp up as quickly as we would have liked to. But most of those hurdles have largely been overcome at this point. And we're really excited about what the future can hold, again, with more MCO contracts, with the ability to expand the program, and to really be able to reach out and serve homeless women in our community as well. So I guess, Stephen, that's back to you.
Yeah, perfect. Thanks. I think we were looking at data the other day together. And I'm not sure if it got captured on that slide, but I think it said 7,000 homeless just in DC. So you see 35 adults is like just, a raindrop in the ocean when you think about, okay, well, how do we scale this up? So thank you to all the panelists. We do want to add one more perspective to the story, and that is a short, quick video to show you, actually, of a gentleman named Gregory, who has been a participant in Hope Has a Home.
I was homeless at one time, and I was out on the streets doing drugs. I just wanted to be into the in crowd. I always wanted to be with somebody that's doing stuff. I am 14 years clean now, and I want to do better. I was in the hospital, and my lungs and my kidneys had failed, and I was all banged up. And this hospital, Georgetown, saved my life. And they called a lady named Miss Arcemo, because my time was up. She interviewed me. And when she was telling me about Volunteers of America, I said, oh, I like that place. She was like, oh yeah, she said, well, you could be a good candidate. And I've been here for almost 2 months now. The staff and stuff is real good. Miss Boomy is a nice lady. She helped me get all my medicine. And when I was at the other house, a lady named Miss Fran, if I'm asleep, she would wake me up and bring me my medicine. It's a good place. I'm not used to the warm welcome that people giving you. Sometimes you just don't get that tingle with that warm welcome. They give me good services. They feed me. They help me out with my medicine. I get to wash my clothes. I get to take showers. There's no string attached, Because some people, when you get off of drugs, some people don't know how to pay rent. Some people don't know how to clean up. Some people don't know how to do these things, You know, you have to learn these things, and this place right here helped me learn these things to do stuff that I want to do. I'm saving my money. I got me a little job, little program that I went through. I'd like to thank Volunteer America for having this home for people who like me. It's a wonderful place. It's giving me hope, you know, giving me pride and dignity to do something for myself. It's really, you know, a beautiful place, so I won't be out in the streets.
Okay, well, that should bring it home for you. It's always great to see a story told like that. Sorry, I just wanted to pause with that. So before we open it up for questions, we actually have one more poll to ask you, which I think comes at a good time actually after that video. The question being, what percentage of individuals do you think experience homelessness after their first night leaving the hospital? Give you a few more seconds. Yeah, again, clearly an audience who understands the depth of the problem. That's right. 75% of people experiencing homelessness will come out of the hospital and spend their first night at a shelter or on the streets, and that's 11% actually on the streets. My wife's a nurse practitioner and tells me about this issue often. Actually, they don't know what to do with these individuals when they let them out of the hospital. So wanted to make sure that we have 25 good minutes for conversation. Wondering about our chat questions. How about this? I'm going to ask the first question, and then while she's answering, I'll check in with my colleagues here, see if I can get a heartbeat on how many other questions are out there. So let me ask this of Allison. So Allison, clearly innovation in the space, clearly needed in DC. So what is the challenge to scaling this up here in the local market and replicating it across the country so we can go from serving 35 individuals to 350 to 3,500 and so forth?
Yeah, it's a great question. I mean, I think one of the things that we observed in our early work looking at the range of medical respite programs across the country, and there are, I should say, over 100 medical respite programs across the country, but I would sort of borrow the terminology from Silicon Valley and say that there's version 1.0, 2.0, and I think what we found with Hope Has a Home is we're sort of bordering on 3.0. And I think partly what's really needed is to define and sort of say this is the model that we have to operationalize, and we have to do it with enough fidelity to that model so that we can start to have confidence in our ability to drive the outcomes that we want to see. And obviously there's local context and variation that informs our ability to do that. And from our vantage point, when we look at financing, a big aspect of that is quite honestly reimbursement. So the extent to which there are whether it's a Medicaid expansion state, as a first pass, another is whether or not there are services that can be reimbursed through traditional means. So, when you look as a whole, you need to see, you know, a clear statement of the program we want to have and a clear value proposition for all the partners. And I think that is starting to emerge. I will say that having done this work in the district, we've been really excited to be a part of helping to stand up 6 other medical respite programs that are in various stages across the country. So I think there's an acknowledgement that this version 3.0 is where we want to go, that we kind of know what we're aiming for. And then it's a matter of figuring out how to navigate all of those various local issues like reimbursement in order to have a fighting chance of standing up a sustainable program that addresses all of the objectives that all partners have.
Great, thanks. So, and building upon that real quick, Rosalind, I imagine you have to go into the executive suite and fight for things like this that you believe, you know, make a difference. And you got to talk to people who, some are going to be like already converted and others who, you know, just don't think this way. So what do you have to bring to the table to bring everybody on board at an insurer?
Thanks, Stephen. So I think the thing that you have to do, and we sort of alluded to defining medical respite, and depending on whether you're in the C-suite, depending on whether you're speaking before a hospital board, you have to define it in terms that people understand. You have to sort of hit their pain point. And as Jana alluded to earlier, there is pay for performance in the District of Columbia, and some of the individuals that impact that are folks who are best served by this model. So that's one conversation. You have to educate folks as to why medical respite makes sense. I think everybody understands the problem, but not necessarily the solution. And you have to put it in terms that everyone understands. This is a viable solution. That impossible thing that you had before, this now can help. So as I mentioned earlier, the subpopulation that sort of rotated again, that line on your monthly operations report where you go, gee, ER utilization, or gee, hospital admissions, you know, you have to speak in those terms, and then people really understand, it really can work, and we're showing that. The more that we do, the more we're showing that.
Great, thanks for that. Do want to capture some of the questions coming in on the chat. Jane or Jana, how do you find permanent housing at the end of the process is one of the questions being asked as you smile.
Yeah, the unicorn in DC, right? The elusive unicorn in DC is permanent supported housing for our folks. It's not an easy task. And that's where that partnership with Pathways to Housing for us has been so critical and such an important component of the success of the program. You know, between Unity Healthcare for the health care outcomes and that reconnection to primary care that's so important to get it started, it's that Pathways connection. Arsema, who you saw mentioned in the video by our client in the presentation, just does an outstanding job of navigating the DC housing COC system in finding the housing, getting the guys qualified for it, and marching it through to its final end in helping the guys get the housing. She just really is an expert at that. And I do think that that's part of the success of the program, is really having paid attention to that piece of it and how important it is, and that is really a specialty area of practice. You've got to have people that are experts in their community on that piece of the work to really make this successful for the kind of long-term, I think, cost savings and health improvement outcomes that we're looking for the men that we're serving.
And I was curious when you were speaking earlier too, are the two facilities, are they also hard to put together? Is that a barrier to scale, the actual homes themselves with the beds in them, the respite beds?
Well, I think depending on where you live and what your market is like, it certainly can be. We had the advantage in DC of having some properties that we had already identified for this purpose. And they are fully handicap accessible. first floor ramblers with big bathrooms where, you can even wheelchair someone into a shower if you needed to, for example. So we did have some properties that were available to us for this purpose. But yes, depending on the market and where people might be looking to replicate this or expand, finding the right property to do it, I think, is really important as well. Again, these are not shelters; they are homes.
Right. Okay.
Even if I could just build on a little bit to connect the dots, I think one of the dimensions of this program that makes it more like a version 3.0 than a version 1.0 is the length of stay. And that is very intentional, acknowledging how long it takes oftentimes to connect somebody to housing. So it would be much harder to get that higher proportion of individuals connected to housing if this were your typical 15 or 30-day medical respite model that just looked like phase 1, if we didn't have that phase 2 built on. So just wanted to connect those dots there.
Great, thank you. Don't know who to direct this question to. This is a chat question, so I'll let anyone jump in. Someone's curious, is medical respite a covered benefit under DC Medicaid, or is this a value add by AmeriHealth? I guess this could be a Rosalind question.
Thank you. It is a value add that, again, in order for us to maximize the existing benefits and to really move people to where they need to be. AmeriHealth took this risk. So no, it is not a benefit and account, as you might call it, under DC Medicaid currently.
Okay. Anyone want to add anything to that? Because I know it's a critical piece of the kind of the financial model.
I'll just say that we spent a lot of time figuring out how to optimize reimbursement through the services that could be paid through DC Medicaid, and then to really sort of account for the ones that couldn't and focus on that gap. And, as Jana was noting, we were really fortunate to have access to those facilities. And there's even some differential level of reimbursement that we gained by being able to deliver services in those facility types. Had we been in a shelter environment, we could not have had the same level of service reimbursement. So just wanted to point out that this is one of the areas where there's a lot of geographic variability that I think inhibits that scale dimension, Stephen, that you were referring to.
Someone does ask, by the way, and probably rightfully so, when did this start? Like, what's been the time frame? From Allison, you shared like early research and ideation to like where we are today. So can you give me some hard dates and milestones? Somebody.
How about I go through like ancient history, and then Jana, you talk about program timelines. Does that sound good? So ancient history, the very first meeting I attended in my role at Quantified Ventures 3 years ago was the meeting where my colleagues presented the findings recommending medical respite. And that was a 3-month scope of work. And so we basically started on medical respite in April or May of 2018. Like that's when like we sort of said, that's what we're pursuing, go.
And then just to kind of answer the operational question of how long have we been open? We opened in October of, is that 2019? So we've been open about a year and a couple of months. COVID time sometimes gets away from me. I had to think about that for a minute. But yeah, we've been open just over a year operationally, but it did take a good almost year of planning ahead of time with respect to the partnerships, the funding, and we spent a lot of time, careful planning time with Unity Healthcare and with Pathways to Housing. Some of the staff that are in the homes are actually Volunteers of America, Chesapeake and Carolina staff, but some of those positions, one of those positions is a Pathways to Housing position, one of those positions is a Unity Healthcare position. So there were a lot of details around the coordination of how is that going to work with 3 service deliverers in the same program in those 2 facilities, and to really make that work in kind of a seamless way for the persons receiving the care. So we did spend quite a bit of time together working through those details, developing standard operating procedures for the program, and continue to do that work with our partners in examining how is it going, are we doing what we planned or said we were doing, or what adjustments do we need to make moving forward. That's just kind of an ongoing iterative process. So I don't want to kind of underestimate the amount of time that if you're going to do a multi-agency partnership like this, really spend some time working through that. It really does reap the benefits on the other side.
And one would hope that it could be a little bit shorter because we've learned so much from this journey.
Yeah.
Catherine, you know, we've already mentioned that there's not only the idea of scaling this for men, but scaling and adapting it for women. And so I was wondering if you could weigh in a little bit on what would, in your opinion, adaptation look like for a program that serves women instead of men, if any at all?
That's a great question. So just to back up, I think the sort of gold standard of medical respite that we've had in the city at Christ House, I think you all have really replicated with sort of, it's a freestanding 24-hour care with women right now in the city. It's scattered site in a low barrier shelter. That is our medical respite, which is not a sort of a therapeutic healing environment as the Hope Has a Home model. Really, the video, I think, shows so well how just giving that sense of dignity and a space and a kind of a welcome environment to heal is so important. So all of that, I think, would equally help women. I think that there are, you know, particular attention to some of the mental health piece. I think that women experiencing homelessness, I would say, who are in shelters and on the street, I think have a little bit more struggles around mental health issues, and having that Pathways partnership is so critical for sort of the behavioral health support there. Obviously, there are kind of physical issues, preventive care, routine primary preventive care, the sort of PAP test and referring for mammography and sort of coordination pieces that would be necessary to put into place when we're thinking about kind of how to kind of reconnect folks to care and think about their well-being long term. But I think that the general model of creating a safe, warm space for folks to have dignity and a shower and privacy and support and care is really the key for everybody.
Yeah. Thanks. Clearly, based on the chat, we have some technical practitioners participating today. Let me hit a couple of these questions and leave it to you panelists to decide who's best to answer. Let me start with this one. This person's really curious. I mean, bottom line, how many funding sources did you have to access to make this work from soup to nuts? As someone who works in impact investing, I appreciate that question. And let me add a part B to that, which is why only 8 units, they ask, because it seems like you could spread your development costs further on a larger physical project like 24 to 32 units, you know, so why keep it so small?
So I can start by saying that there's been really singular source of funding primarily to this point, but there's envisioned diversification through contracting with other MCOs in the district. And, you know, that speaks to both sustaining and scaling the current program and also expanding it to other populations. I think partially the size question is one where you want to have confidence that you're addressing the sort of right level of need in the market. And so we think the project team is with me in sort of agreeing that while we had a lot of educated guesses, they were still nonetheless guesses. And so, you know, part of the size determination was based on the homes that we had. So to Jana's point, those homes were available and they seemed like an ideal setting for this type of program. But partially, we didn't want to start by overextending without first really understanding what it would take to operationalize the program and what the real need in the market looks like, so that we could then grow with the flexibility and ability to adapt to what the market demand actually is. The one other point I'll offer on the sort of size question is there are trade-offs. We hear a lot from other programs across the country that are either co-ed model or have different settings where there are more humans being served, that for certain individuals, particularly those with a history of trauma, that's a really challenging environment. And so, you know, it almost speaks to the notion of actually trying to build these programs in smaller, more intimate settings. And quite honestly, in the era of COVID, which none of us anticipated, I'd say that was a huge lucky break, right? I mean, Jana, I'd love to hear you speak about the experience, but I don't think you would have been able to keep the lights on and the doors open as long as you did if the facility had been larger. So would love to hear your thoughts on that if you have any to share.
Allison, I would agree with you. You know, I think one of our advantages going through COVID, that although it slowed us ramping up to the scale or filling the program as quickly as we would have liked to in its first pilot year, the advantage is because it's small, we were able to really put into place some of those public health good measures that really did keep COVID out of our population. And we were able to continue to admit people once testing ramped up and once we had the adequate PPE and the adequate cleaning protocols to continue to take referrals and to continue to serve people during this environment. I think that would have been a real challenge if we had had, say, a 20 or 30 bed facility, trying to manage that in. So yes, to your point, I think that ended up just being kind of, you know, obviously we didn't predict COVID. That ended up being a piece of the model that really worked. But I think the other piece of that on the smaller scale that I really liked, you know, as a clinician, I'm an independently licensed clinical social worker as well, is the intensity of the relationship building and the staffing to the number of men that are in the program. You know, they're trained in motivational interviewing, they're trained in some of those mental health best practices, and it is a low barrier program where we will accept people who are actively using substances as long as they're not using on site, they're not storing, you know, drugs or alcohol on site, and as long as they're able to manage their behavior. You know, we kind of focus on how people are interacting with other people, but as long as people are able to keep a respectful home-like environment, we kind of use that in motivational interviewing then to address those other needs with people. And I'm not sure that you can get to that place in a phase 1 house that kind of has that pressure around resolving the medical issue in that 30 to 45 days if you're in larger settings, that there's something to that intimacy and that smaller scale that then allows you to build the relationships that carry over to phase 2 that then help with the permanency that are going to lead to then those improved health outcomes over the long haul. So I do think that part of it is important as well.
So the takeaway, I just want to, so you both are saying basically, if someone's on the call listening from another market, another part of the country, thinking about this a year from now, post-COVID, your recommendation is to start small as well. You would not encourage someone to start at 20 and 30 beds. There's a lot of value in starting small.
Yes, of course, with the caveat that if you can create intimacy, right? If you can create the spaces, like if your program of 50 is in, 5 different houses or, 6 different houses, then that shouldn't necessarily dissuade you if that really is what the market demands.
Gotcha.
But I think the attention to the setting that is both conducive for staff to be able to deliver their best treatment and for the client to be able to truly take that and benefit wholly. I do think there's something there that we've observed in this program. How's that for hedging?
That's great. I was expecting nothing less from you.
And I guess just as somebody who has worked with Unity Healthcare in providing medical respite for years and watching their model, they did start a medical respite program back in 1985. It's a 33-bed facility, but it is a facility that I think that because of the way that it's laid out is able to create. There are smaller rooms for folks, between 2 people to a room, as many as 8 people in a room. And so obviously you can tailor that to kind of who would benefit based on trauma or their medical condition to kind of a more intimate space versus larger. And so I think that form feeds function, right? So if you have a space that, as Allison mentioned, can create that sense of intimacy, and as Jana said, and provide space for the staff, then you could start, I think, a little bit bigger. But programs like Boston Healthcare for the Homeless, which I think has over 100 medical respite beds in one space, is really more like a hospital. And so that just requires much more thought in terms of how you scale up at a hospital level. And they had years and years of practice doing medical respite in a home before they took that step of kind of scaling up in that way. So I think it's possible with the right space and the right thought to creating those intimacies.
That's really insightful. Thanks for that. We are at the end of the hour, and I see people starting to pop off to get to their next Zoom meetings. So if we were in a big room, I would tell the audience to applaud our panelists and thank you for your generosity and time, as well as the panelists joining me in thanking all of you who came to listen and share and learn about this really powerful program. We will follow this up to everyone with an email. It'll include a link to the recording of this webinar, which you can share with others, of course, and the video that we shared, and a quick survey. Always helpful to hear from you in terms of how we're presenting the information and its relevance to your work. By all means, you can reach out to any of these panelists yourself. And like I said, one of our main goals today has been to invite new partners to the table to help scale this program here in DC, expand it, innovate with it. So thank you again for your time, and have a beautiful week.